right, ladies and gentlemen, we appreciate you joining us this afternoon. I know we stand between you and a fun party. I heard togas. I didn't bring one, but I've also been told bed sheets. So we'll leave it at that. But we'd like to welcome you all to our presentation today, Defining Social Determinants of Health and Health Equity on the Ground. The last session was talking about building a community, and our goal here is to help you all engage that patient community further, deeper than maybe you've thought of before, and how we can really come around patients to drive change further.
I'll turn on my mic and then introduce myself. Hello, my name is Austin Williams. I'm the Executive Director of the MEDI Inc. The MEDI is a 501c3 nonprofit organization that focuses on reducing health disparities and promoting health equity through community collaboration and the use of technology. My background is not in public health, and so when I joined the MEDI just 2 years ago, they used a lot of words I didn't know, like SDOH, which I Googled in meetings. And that is how I found out what SDOH is in a professional setting. And what has been really powerful and impactful for me, coming from a community engagement background, I have 20 years of experience in doing community engagement, working with nonprofits, and being able to bring that experience into a public health space and go, okay, now I can help y'all make this make sense to normal, regular, degular people like me. So I'm very glad to be here and share some of the work that we are doing at the MEDI and the ways that you all can work with community members and patients in order to help connect them with essential resources.
Fantastic. My name is Matt Terusco. I'm the founder and CEO of ARCO Advocacy. Our goal is to advocate for advocates, to do as much work as we can to support you all. May you be independent advocates, may you be part of an organization, a disease state organization or other, and ensure that we can collect data and feedback on how well that's working and what still needs to be done to support patients. As you heard in the last session, a lot of support still needed in policy, and we can talk about that as well. But ultimately, what we see is a continued need from industry. Anyone from industry in the house? Fantastic. How can industry better be represented at the table with community-based organizations and nonprofit organizations through the work that you're doing, but also how can we support you in ensuring that your C-suite recognizes the value of that work, which is typically a 5, 10, 12-year struggle in a quarterly and annually budget-focused organization. So that's a lot of what we do. It's always about bringing the data to help drive that forward. I got into advocacy because I myself broke my neck in 2005. It took me 22 years of opiates and just about the same of trying to find a solution to get out of pain. And I've been in healthcare for over 20 years. So if it took me that long to find a solution for myself, what does it take your everyday American? We know they're up against a lot, and they're already starting behind the 8 ball. So the more work that we can do together for everyone in this room, the better off the entire community will be. So from an agenda perspective today, our goal is to walk you guys through and make sure that we level set on what some of these terms are that Austin had referenced. What is health equity? What are social determinants of health? How do we get a better understanding of them? How can we ensure that, we're level set not only on those terms, but where we are as a group? Thank you to those of you who participated in our pre-conference survey to gain some feedback from you all with regards to what that looks like right now, how you're engaging. We'll show you all some of that. We're going to walk you through exactly how you can take action. We don't want this to be any type of a conference where anyone's just sitting up here patting themselves on the back, but it's how do we actually take action, knowing and coming together and learning from one another to go out and impact the lives of patients. So we'll dive into some of those case studies. We'll show you some data as well about where industry is in trying to address social determinants of health also. And at the end of the day, it's to ensure that we can all be better and be a better asset to our community. So I love this quote from a patient advocate speaking about what does social determinants mean in the guise of assisting patients. And as you can see here, it's ensuring that we're looking at the bigger picture of what a patient is. What does that mean? If anyone's in the field reimbursement space, we know that everyone struggles to get access to medications through their insurance companies, but what about all the other issues? Just because they're scheduled for an appointment does not mean that they have the child care that they may need, doesn't mean that they have the transportation that they might need, and we don't know the rest of the financial struggles and the full picture of that patient's life. And that's what we are all looking to address.
So I'm going to share some of those pre-conference survey results that Matt referred to earlier. So you can see that, most of the attendants here, or people who participated in this survey, said that they were in the work of addressing health equity, as you should be, because if you were not, that would be really confusing. So well done on doing what you do. What is really interesting about these results, though, are the second and third questions. So the second question, how proficient are you or your staff in community and social services available to your patients? Again, most of you say that you are proficient in that area. But this is what's really interesting.
And real quick, I'll just point out, if you're here, you're already different from everybody else, right? If you came to this conference, you came for a reason. So to see proficient and more of those average scores, just think about where the rest of the healthcare community is as well. But Austin, as you referenced.
All right. So what you see here is that even though many of you are proficient at these resources that are available in your, or to your patients rather, there's a significant number of you who do not feel like you are able to successfully connect your patients to those resources that you know exist. And therein lies a gap that is really significant, especially when we're thinking about SDOH, the social determinants of health, those outcomes that are a result of where people live, work, play, and pray. And so those top three social determinants of health, again, are things that sometimes people have no control over: where they work, socioeconomic backgrounds, transportation, their job. And we're going to get into some of the solutions and how to address these things, how to fill those gaps. But I think it's really important for us to know as we come into this conversation that we know that there are resources available, but we are not always able to connect these people successfully, these patients successfully, to these resources that we know exist. And then come up with some next steps and practical ways that we can address that.
So our agenda for today's presentation, we're going to level set on these terms and topics and make sure that we're all on the same page before we dive into a deeper look into social determinants of health, or as we heard from Austin, the thing behind the thing, as simply as we can put it. And we'll talk about our obligation to assist. This is no longer a should we, but you may be the only other person that patient speaks to outside of their medical professional that they engage with. So it's our obligation to connect folks to these resources. So we'll start off here with setting some definitions for success. And as you can see here, health disparities. It's the current state of where we are, right? So the preventable differences in the burden disease, injury, the opportunities to achieve optimal health experience, all due to, as Austin had referenced, where you live, breathe, pray.
Live, work, play, and pray.
There you go, right? So that's our current reality. There's disparate outcomes for patients, typically by zip code. But as I've also heard it put, at the end of the day, you might be a millionaire that lives next to the doctor that does surgery on you. If you are getting different care, i.e., you got some extra pain meds post-surgery, but unfortunately that led you not to get out of bed, and you got a pulmonary embolism because of it, that is a health disparity at the end of the day. So it doesn't matter what end of the spectrum folks might be on economically, these are all differences in your care due to where you're at, what you look like, where you live, so on and so forth. The social determinants of health, though, these are the non-medical factors. And as I'm sure all of you have seen, these are about 80% of what impacts a patient's health across their lifespan. They're the conditions in which people are born, grow, work, live, age, so on and so forth, and they shape their continuous daily life. So it's where they're at, it's what they engage in on a daily basis, what they do, that ultimately leads to some of the health outcomes. As Austin will discuss further, the thing behind the thing. And lastly, health equity, the ultimate goal. So we have health disparities. We want to overcome those to get to equity, or that state in which everyone has a fair and just opportunity to attain the highest level of health that they can. So with that said, we'll dive into social determinants of health.
All right, so as Matt mentioned, and I shared earlier, the social determinants of health are the 80% of health outcomes that are a result of where people live, work, play, and pray. And it's largely dependent upon environmental exposure. So a lot of times it has very little to do with just a disease state and considerably more to do with the circumstances in which that person was born into. Our founder, the founder of our organization, her name is Audrey Wetzel. She's right over there. Wave, Audrey. One of the things very early on, again, I mentioned I didn't have a background in public health, and very early on when I was like, oh, I just learned what SDOH is after this call, she shared this idea of the thing behind the thing with me. These are my words. This is how I made sense of it in my mind. But she used the example of a patient that had diabetes. And she was like, we might be seeing this patient who has diabetes, and the doctor is frustrated because this patient will not take their insulin. But they might not be asking the right question, because perhaps that patient with diabetes lives in a food desert. And because they live in a food desert, they don't have access to healthy foods. And also, because they are not healthy, because they don't take their insulin, they can't, keep a job. They don't have transportation to get to a well-paying and fair-paying job anyway. So even if they did have a good-paying job that was outside of their food desert, they didn't have transportation in order to get there. Therefore, they lost that job. And because they lost the job, they struggle to pay their electric bill. And because they can't pay their electric bill, they can't keep their insulin refrigerated, which is why they're not taking their insulin. So the thing behind the thing, Matt, if you'll go to the next slide for me, is really like this iceberg. We've seen, I've seen plenty, and I assume that many of you have probably seen this iceberg analogy where we know that the tip of the iceberg is right there, but we don't necessarily understand all of the other factors that are happening beneath the water. The thing behind the thing is really being cognizant of the fact that there are all of these things happening beneath the water, There are all of these things happening beneath the water. And it's up to us as patient advocates, as community health workers, as advocates in general, as people who just care about their family, their friends, their brothers and sisters next door, their neighbors, to go, hey, I recognize that perhaps your circumstances are such that you have other things happening beneath the water that need to be addressed if we're actually going to strive for health equity. And as Audrey often says, all ships rise with the tide. I'm from Charleston, South Carolina, so we live on the beach, and I assure you, all the things rise with the tide. And when we take the time to address these things beneath the water, we're able to see health equity rise, we're able to see health disparities fall, and we're able to help connect these patients with the essential resources that they need. Some of the work that the MEDI does is specifically in connecting patients and community members to essential resources in their area, and we'll be able to talk a bit more about that here shortly.
Let's dive into our obligation to assist. And we'll talk a little bit about, where are we right now? Where do we start? Okay? As Walt Disney said, the way to get started is to quit talking and begin doing. And what's been interesting to watch since COVID has been some of the industry's response. When I talk industry, I mean not just pharma and biotech. I also mean payers, PBMs, so on and so forth. So diversity, equity, and inclusion popped during COVID. It really became something that everyone was looking into and trying to affect change in, starting to die out. Same thing with social determinants of health, unfortunately. And as we look at the data, as I referenced at ARCO, we run what's called our Elevate report. Patient Insights, Elevated Healthcare. This is feedback from patient advocates, professional societies, and community-based organizations. Where I'd like to begin is giving you a view of what we have seen based off of health literacy. When asked, what do you believe the appropriate grade level is currently of the patients that you serve with regards to their health literacy, you can see that right around 5th grade is the average, okay? Not so surprising. Unfortunately, the federal government puts it at 6th grade, yet they have an asterisk in that data set that says 54% of Americans fall below this number. So I don't know why they said it at 6th grade, honestly. And this is a big problem when we talk about disease awareness and education and making sure that folks even know what insurance benefits are. What I will say is that in our report, we look at 23 different disease states. So this number varies wildly by disease state as well. The more chronic conditions, diabetes, COPD, heart disease, so on and so forth, actually skew closer to 2nd and 3rd grade. Whereas your rare diseases and your cancer patients skew further towards 7th or 8th grade. Not surprising when you're thinking about cancer and rare disease. Cancer, because of the lethality, rare disease because of the diagnostic odyssey that most patients have to go on to get a diagnosis, so they're self-educating. But needless to say, this is where we're at now. And I'm sure you'd all agree that we need to do a better job of educating patients. And what are the areas of support, right? So when we take a look here, what you are seeing is 9 different areas of social determinants of health. And what we're asking in the yellow is, what is the level of support that you're interested in receiving from industry, from anyone in the for-profit medical sector, okay? Pharma, biotech, med device, so on and so forth. And you can see it doesn't necessarily always line up with the level of support that they're getting. That's what the blue line is. But you can see that the top issues for advocates, in their opinion, are A, individual education, going back to that health literacy component, social support networks, which is interesting because if you go back to just 2015, many advocacy organizations, big disease state advocacy groups, were fearful of Facebook because it may take their patients, right? Creating groups on Facebook might not have them come to them for resources. But thank God we had them during COVID because it allowed those folks to get together. But this is a continued issue of getting folks who are having similar experiences together. And thirdly, systemic barriers to equity, right? How can we focus on those policy issues that can drive better change, more impactful change, by changing the system itself? And as I referenced, we're measuring the impact of these organizations. And you can see here that the #1 organization last year, we do this annually, was Johnson & Johnson, followed closely by Sanofi. And you can see where all those other organizations fell out. This is to show you that they are doing work in social determinants of health. They are trying to address the issues, albeit based within the disease states that their products are in. But I have to point this out as well. You can see that top number there for Johnson & Johnson, 3.76 out of 7. Okay? So we're not even getting close to a 4 statistically. So we're not even at average. Yes, industry's just starting to get their feet into this. However, unfortunately, they're not quite getting the job done. And there's a lot of reasons for that. Most of them are because of a lot of the reorgs that are taking place within pharma and biotech companies at this moment. Where does advocacy sit? How is it viewed by the organization's executives? So on and so forth. So know that they are looking to do work there. They may not know exactly how to do it. That's where you all come into play. How can we guide them to do it better?
And really, the way to do this, I put everything Matt just described with biopharma into a category called tensions to be managed. If you were here for the last session, then you know that there's disruption that needs to happen within the system. But if you have to operate within the system in any way, this becomes a tension to be managed. But while we're managing that tension, what can we do? We can get real. So I think when we're thinking about the thing behind the thing, again, the disease state is just the thing, but the social determinants of health are all of the things behind the thing that actually we need to be asking about. And so the way to do that is to, one, recognize that there are things behind the thing, that there are deeper issues and concerns that we need to be addressing and asking questions about in order to identify the real barriers that patients are experiencing that prevent them from experiencing their best health outcomes. The second thing is to explore. I even say to my children, be curious, not corrective. Like, it's easier to say, do this, do this, do this, do this. But if we're curious, if we ask good questions, I find that we're better able to understand where our patients are coming from, what their barriers are, and what are the things that are keeping them where they are. A lot of times, it's easy to believe that a community member or a patient, in some ways, like, they have to choose their own choice, and that's true. We can't make them do anything. They have to want a different outcome. But at the same time, part of that is going, hey, I'm going to ask you some questions, because they might not even realize some of the barriers that they have. So when we explore, we give them an opportunity to realize that, oh, wait, these are barriers to my health that perhaps I hadn't connected before.
Yeah, and I'll steal a term from Matt Zachary if anyone had a chance to run into him over the last 2 days. We have to ensure that patients know that shit exists. Okay? As he calls it, KSE. And I'm sorry for cursing, but that is the problem that we face in healthcare. People just don't know that there might be a solution to this thing that they don't even attribute back to their health. Mm-hmm. So helping them to understand through exploration is key.
Yes, and as part of that exploration is asking good questions. So in one of the conversations I was having with a university's major medical school, they were like, our nurses don't have time to ask these questions, so we're just using some canned questions that we found online in order to get paid. And again, attention to be managed, but at some point we have to provide these people with the questions to ask, even if they don't have time to do it. We have to make sure that these nurses, these doctors, understand the barriers and that they are doing what they're supposed to do in order to connect patients to these essential resources. And then the L in get real is to listen. If we listen well, we can learn more. And being intentional about the information that our patients are trusting us with, that the community members are trusting us with, help us better understand where they're coming from, what their barriers are, and then how to ultimately address them.
And Austin, I want to tee something up for you, because I think this goes without saying, but one of the true first steps in all of this is to understand our own implicit biases.
Absolutely. Right? So I was actually just getting ready to share about understanding the cultural differences that can happen when you're even advocating, when you're even getting real, because part of getting real too is like getting real. You know what I'm saying? Like, oh, let's move past the appropriate thing or whatever in order to address what might be a true barrier. So for example, there are communities where mental health is very taboo even still today. Don't you go out the house and tell people about what's happening here. Mm-hmm. You better not do that. They're laughing because they know what I'm talking about.
Pretty much all of South Carolina.
Okay. That is a cultural barrier to mental health, right? So in getting real, we have to also understand that cultural barrier that might prevent them from seeking help that they may very well need, or their child needs because they're suffering from a real mental health crisis, or they're on the brink of it. That is causing all kinds of other problems, because then that parent can't go to work because their child is having a mental health crisis. And because they can't go to work, they can't pay their electric bill. And then we end up with the thing behind the thing all over again, right? And so these implicit biases, our implicit, explicit biases, our prejudices, all of these things can be alleviated if we recognize that they exist, know it exists, as Matt says, and then we get real about it, and that we're not afraid to ask hard questions, or even allow them ask questions that maybe makes you a little uncomfortable, but it gives that patient an opportunity to be honest. Because if you give them space to be honest, they're more likely to be honest. So the way that the MEDI addresses social determinants of health is that we have a platform that connects patients and community members to essential resources in their area. They can simply type in their zip code, and they will have access to all of the free and reduced cost services in their area, and it includes education, transportation, housing. The list goes on. I'll show you some more about that in just a few minutes. But this allows our patients and community members to be empowered to take their health into their own hands. They can come to you and they can get support, but also if it's the middle of the night, 24/7, no wrong door, no wrong time for them to have access to the resources that are available in their area. It can help them identify social SDOH barriers. It can connect and create a closed-loop referral system because referrals can happen directly within the system. And then it gives us an opportunity to support these patients and community members holistically. If we can go to the next slide. So this creates really a cycle and a system where there's awareness, accountability, and action, right? Because when patients can both connect with you as an advocate or connect with someone who they know has their best interests at heart, where they can ask questions and get the information that they need, but they also know, hey, when I leave here, I can still have access to this advocate, but I also don't have to continue to go and repeat my devastating story over and over and over again to get help, because that gets old, right? If I'm having my rock bottom moment, maybe I don't want to repeat it 15 times to 15 different organizations, but if I can go to one website and it will show me all of the resources available in all of these different areas, that lets me connect to these resources with dignity and ease. And then it creates action where they can take steps and take action toward finding the resources that they need, and that they can take their health into their own hands as well.
Yep. And Austin, you may touch on this in the next slide, but there's a lot of tools, right? There's a lot of software, even some vendors here for the conference. Talk about the issue about self-navigation, so to speak, and that it might not be for everybody.
Sure. So I often tell people that technology without people is pointless, right? So if we have technology and it exists, but people don't know about it, well, that's pointless. And if we have technology that people know about and they're looking for resources, but the organizations that provide the services don't know that the technology exists or that people are trying to connect with them, you know what that still is? It's pointless, right? And so in order for technology to serve communities well, and this is really the heart of the MEDI, it's essential that we are creating an ecosystem of care, that we are working collaboratively with patient advocates, with community-based organizations, with service providers, in order to create a closed-loop referral system where patients can go in and look for services themselves, where patient advocates have a one-stop shop where they can go, oh, look at all of these resources. And one of the things that we as an organization focus on is being a nonprofit's nonprofit. So we want to help and equip community-based organizations know that this platform exists, and then leverage the data and analytics that comes with it in order to continue to help them do the good work that they do for a good long time, because it's hard out here in these nonprofit streets. Can I get an amen?
Fantastic.
Thank you. So this is what our platform looks like. Again, you type in the zip code, and then immediately it will show you the number of programs that are within a particular area. So you can see that there are over 3,000 programs within this particular zip code. And then there are plenty of categories. So if you are an advocate and you would like to utilize the service, you can go to www.themedi.org. THEMEDI. You could type in a zip code wherever you are. It works in all across the United States. You type in your zip code, and then you have access to all of the resources available within that zip code. And again, we're trying to build this ecosystem of care. So what the MEDI is focused on This technology does not belong to us, but the way that we do community engagement is, I think, what makes our organization special. Because what we are working to do is partner with the boots on the ground, the people who do the work, and make sure that they know how to leverage this technology in order to do, again, the good work that they do for a good long time. And that includes being able to update the platform, suggest programs. If the program is not up to date, say, hey, this is actually what this organization's hours are, so on and so forth.
Awesome. So case study.
All right, so this is a case study. I think case studies can be really helpful, but this model of community engagement that I keep referring to is tested in some ways. In 2022, the MEDI was awarded a $2.1 million HRSA grant to support vaccine confidence related to the COVID-19 vaccination. And we did this work in 7 states and the District of Columbia. And in 5 months, we were able to help over 11,000 patients get vaccinated. And the reason why, thank you, the reason why this particular project was so impactful, I'll share a story with you all, is that what we did not do is try to go and independently vaccinate patients. We, as an organization, we are not a service provider. And so what we did was we strategically worked with service providers and community-based organizations, and we brought them together collaboratively in order to create vaccine clinics at places where we knew organizations were already going to be and patients were already going to be, because we understand social determinants of health. So during this period of time, we also knew, for example, that they were giving out significant incentives in the state of California, for example. We'll give you $100 if you get your COVID-19 vaccination, and no one would show up. But people were showing up because maybe they didn't have transportation, so they had to take off work, they had to find some transportation, they had to get there. This cost them money. The $100 didn't make up for it, even if it was going to keep them healthier in the long run. So what we did was, again, we worked with organizations at events where we knew people were already going to be. One of these partnerships was the Palmetto Community Action Partnership and the South Carolina Community Action Partnership Association, which leads the entire state's CAP agency. And they were having these regular events. At one such event, which was in a public library in Orangeburg, South Carolina, so a pretty rural community, there was food distribution happening. There was rental assistance, electricity assistance. This was a fair of sorts where people could come and be connected to resources. We brought in DHEC, we hosted a vaccine clinic there, and we also had incentive gift cards that could be used anywhere. They were $50 gift cards. And one woman who was there for the food distribution, she went up to the vaccination table and she said, hey, if I get vaccinated right now, do I get this gift card? And the community health worker said, well, yes, of course you'll get this gift card. She was like, and if my daughter gets vaccinated, will she get a gift card? I said, well, yeah. And she said, can I go get my mother too? And would she get a gift card? We said, yeah. And my baby too. I said, yes, all of you can get vaccinated and receive this gift card. She started crying. And she said, I'm going to get them because if we do this, we'll be able to pay for our groceries this month. You know, we think that it's about the thing, but it's never the thing. It's always the things behind the thing. The thing is there, it's real, it exists. But for this woman, her positive health outcome was not just getting a COVID-19 vaccination. It was being able to buy groceries and diapers for her baby that month. And that is a case study and why understanding SDOH barriers is so important, right? I believe in transparency, and it sounds weird to say this at a health conference, but autopsies, because when a project is over, we need to do an autopsy to see what worked and what didn't work. So one of the things that we look back on during our time, this is impactful work. I think we did a good job. But an area where we failed is that, in our opinion, looking back, what we should have done is that every single clinic that we did, anytime we did an event, We should have made sure that the people who are getting vaccinated had access to the Medi Community Resource Center, and we didn't do a good job of that. And so in plenty of ways, we missed the mark. And it's up to us to, again, get real and be willing to recognize, explore, ask questions of ourselves, and then listen to feedback about ways that we can do better.
Yep. And one thing I'd add to that, Austin, is just the sheer fact that it wasn't the Medi that was going out. I think, from an industry perspective, so often we go out and try to say we have to do X, Y, or Z. That's not the case. In fact, that can actually be more difficult or might be a detriment to the program. Trust is such a commodity, it's slim supply.
Yes.
So utilizing the organizations that already had the community's trust, that they already had respect for, and utilizing those organizations to be the front lines for it is what helped make it so successful.
Absolutely. We call this relational capital. So we were leveraging other community-based organizations' relational capital in order to affect change. And some of our biggest successes, one event, we vaccinated over 200 people at one event, and it was because the community health worker was also a pastor in the area, and it was at his conference that he had to be at. So we were leveraging this relational capital. Yeah. It makes a difference.
Yeah. And I think that's sometimes where industry gets tripped up, is that your name doesn't have to be on it. You can go, you can attend, you can fund, but perhaps it's not led by you. You're just in the background. And I'll also, give a shout out to the community-based organizations. I think that so many of them go under the radar in the healthcare space because they may not have some sort of healthcare in their name. But again, if we're talking about the thing behind the thing and dealing with patients and that 80% of elements that impact their health, those are the people who that's their job. It's to be the boots on the ground, to be in the community, to know what's going on and have a pulse of that community. So to utilize them as the front folks and those that can help guide you in industry, I think is vital.
So ultimately, this is what we for sure know because y'all are in the room, right? We want to help our patients, and we can help. And so each one of our organizations are able to do this. The Medi Community Resource Center specializes in, again, leveraging technology to connect community members and patients to essential resources in their area. And we do that by using the power of community engagement, people power. We use people power in order to affect change. And the Culture Catalyst is one of the Medi's partners that specializes in doing community engagement training specifically. So when we're talking about how to actually get started, it's by being willing to collaborate and work with organizations who are already doing the work, to Matt's point.
Tell me a little bit about Culture Catalyst from the perspective of, as we discussed it, you saw some of the requests, so to speak, for training. It's how do I ask those questions, or how do I get more comfortable? How does the Culture Catalyst aid in that?
So really, I think there are things that we've already talked about in this conversation. What does it look like for us to get uncomfortable? And what does it look like for us to be self-aware enough to know what are our barriers to asking the good questions, right? And that's where the work of the Culture Catalyst is really impactful, because we help you identify what are your barriers to being able to see patients' things behind the thing. And then we give you a plan of how to implement and affect change within your organization or with your patients or as an advocate and as an organization in order to alleviate some of those biases, remove those barriers, and then have tangible, actionable steps to actually make a difference, not just for that one patient, but for all of the patients and their communities that you may touch.
Fantastic. And from my perspective, Elevate is our market research arm. It's our ability to get out and understand the impact of industry in the community directly via voice and feedback from the folks that are your customers. So that is one of the main drivers of what we do. Is if we're going to advocate for you as advocates or as field reimbursement, and what's the value, we can say the things that you might not be able to say internally. We can be that voice for you, i.e., you will drive commercial success if you are doing advocacy well. Let's put it out there, right? But internally, you can't say those things because of wonderful compliance. I'm sorry if anyone's in here from compliance. But the data speaks, right? And the data shows the value of all the work that gets done in the community. If you are in advocacy and you're experiencing the wonderful downsizing that's going on post-IRA, we also have benchmarking data, our bioadvocate benchmark on what is the right size, budget, so on and so forth, of an advocacy function within industry, okay? And then ARCO, from the strategic point of view, like Culture Catalyst, like the METI, we come alongside you not only to help you understand the data, but build a strategic blueprint to how do we get better year over year and drive and speak the business language back to our partners internally. So we're here to help. We want to aid you and advocate for you as advocates to the best of our ability. And for those of you that are independent advocates, I had the privilege of working with Rachel. I think she may have stepped out. Oh, there she is. On the impact of independent patient advocacy, which we presented last year. So I love working with the independent community, and I continue to advocate for you all to industry as well to ensure that they are aware that there are these wonderful people in the community that are doing God's work that you need to support. Okay, so thank you for all that you do. With that, we talked enough. Let's open it up for questions if there are any. Yes?
Can you guys hear me?
Yeah.
I'll repeat it.
My question, it's been like a surrounding topic since the whole conference, just pretty much about our advocacy endeavors and how we aim to make them sustainable. So like how we talked about the case study, which is amazing by the way, but there's I come from the clinical research side, so patient mistrust when we just insert ourselves and then we leave. It's like, okay, like you're only here for for a thing. It's more advantageous, more transactional, if you would say,
Yes.
than it is you actually trying to help us. So with Medi or just in general your personal experiences, how do you maintain that sustainability of it?
I think that's a great question. She was asking about the sustainability of impact and of advocacy. And I think one of the things that we do is that we are partnering with community-based organizations that are already there and will be there when we leave. I think that becomes the magic sauce of sustainability, because we're not just trying to be like, hey, we did this thing, but instead we're going to partner with this organization who's been here. You know them, and we believe in them. And so we're going to get behind what they're doing, and we're going to support them. And that's why we say we're a nonprofit, because it's not just about the work that we do. It's about us working collaboratively with other organizations, because we believe that the best way for us to move forward is together.
I would just add that transparency obviously is always the key, right? If it's going to be transactional, because it might have to be, as long as they're aware of it up front, that this is the effort that we're looking to put forward. But if you're doing it alongside of someone who's going to remain in the community, they can continue to get in touch with you. That's really the key. That A, transparent, B, over communicate as much as possible.
I think in healthcare, I think a lot of folks still haven't really understood the value of addressing social determinants of health, and assume there's not enough data behind it. Like, what would you say to the folks on like the ROI of addressing social determinants of health in healthcare as a whole?
One of the projects that we're working on right now is focused on the employer population, and specifically the ALICE population of employees. So ALICE stands for Asset Limited Income Constrained Employed. So they're the people who live paycheck to paycheck. 72% of Americans live paycheck to paycheck, right? So when we're thinking about the return on investment, we can really address this in a lot of different ways. We know that social determinants of health costs us money. We know that when people don't have preventative care, it ends up costing taxpayers money, because then, that patient ends up with stage 4 cancer because they didn't go get regular tests done and regular care. These are things that were preventable that end up costing us more money. But even in, for example, an employer space, when we're dealing with the Alice population, we know that it affects the bottom line of companies. And when it affects the bottom line of companies, it is affecting economies. And when it affects the economy, it affects jobs, right? So I think when we talk about the return on investment of making sure that we have a healthy workforce, we have a healthy population, it's important for us because we live in America that acts like America sometimes, that we need to actually speak the language that we know will speak to the people who make the decisions, right? So I think going like, hey, this doesn't just affect our bottom line as a state when we're using our taxpayer dollars to pay for charity care or Medicare or Medicaid or whatever, but it's also affecting our economy. It affects our workforce. It affects whether or not people end up with substance use disorder or mental health challenges because they are spiraling because of these other barriers that they have. So when we connect the dots intentionally for people, I think it makes it make more sense. Does that make sense?
And from an industry perspective, I would add, if you consider the fish bowl, a fish bowl full of fish, those are the patients that are already seeking care. From an ROI perspective, addressing social determinants of health are adding fish to the fish bowl, right? We can't treat patients who don't show up at a practice or can't get to an infusion, right? For those of you that are in field reimbursement, I mean, social determinants of health are one of the major barriers that limit that patient getting the actual infusion completed, right? So the ROI is there. The ROI is there in clinical trials and just the ability to complete one and have appropriate diversity metrics, so on and so forth. And we know that for every trial change, it's about $250,000 out the window, right? So there's a lot in speaking to a business that's in healthcare that addressing social determinants of health will massively not only accelerate the financial impact, but let's face it, I believe it was a Pew Research study, pharma ranked behind Congress as the least trusted industry. If we're going to change that, it's going to take investing in the community. And we do that by addressing social determinants of health. Any other questions? Yeah.
This one I don't know if you'll be able to answer, but just based off of what you talked about with empathy, because most of the stuff you talked about, we kind of also discussed during our presentation yesterday, so we're like jumping and stuff. But I guess on the topic of patient mistrust, and I've realized that the patient experience starts before they get into the clinic, but even when they're at the front desk, the least paid person is the first person they see. So their attitude, their character, everything, and then by the time they get to the nurse is being rude. How much more the doctor? It's like I don't even want to listen to anyone because the first two encounters were already bad. But down to the provider specifically, like I guess I'm not too aware of this, but are there programs in place that kind of help doctors or providers, clinicians, whatever, just pretty much bring back the humanitarian, just the humanitarianism and just the soft skills? Like you talked about open-ended questions. It's crazy how so many people can't have a conversation and ask open-ended questions, because sometimes as a patient you don't really know exactly what you want to say, but we're the ones who have the knowledge. So it's like asking questions in a strategic way. Like I think we all need to go back to like communication skills school or something, like maybe having like refresher courses every year to help us just remember how to do that. Because I find myself when the doctor leaves, I'm like, oh, I did have something to say, because of the conversation, but of course there's not enough time to even have those conversations. So yeah, I know it's not really a question, but I just wanted to put that out there.
I think that is part of what the Medi and what the Culture Catalyst does specifically. Go like, let me teach you what you need to know in order to have the soft skills you need in order to ask these questions well in the amount of time that you need to ask them, right? Because honestly, have you ever met a person who they're just the person where strangers will tell them all their business? Y'all can think of like that one person, like you might be a friend, they're at the coffee shop and that person next to them was like, I'm having a terrible day. My wife just left me. And you're like, hi, nice to meet you. That person, that's a skill. That skill is empathy. And when we recognize what are our barriers to communication, we can unlock the skill and gift of empathy, and it does change the way that we interact with one another. So that's a part of the work that we do, honestly. And yes, it's a skill, and it's something that has to be invested in, to Matt's point. I know we're running out of time, so.
Unfortunately, it's a skill that's not taught in med school, right? But as I referenced, a lot of it's because of these things, right? And we are so, time constrained, and our attention is so restricted because of them. But I'd also go as far to say that Google is a social determinant of health. If you don't know what to search and how to search, what you get back is not going to help you, right? So it's really investing in that time with your physician or PA or NP or whatever it is, but how do we better prepare patients for that? The Gen Z and lower, or even Gen X and lower, we'll ask questions. We're not afraid to maybe challenge authority. But for our parents and for anyone 65 and older, that's not the world they grew up in. So challenging your doc on, is this the right thing? And, I heard about X. It comes off very differently in their mind. We need to empower patients to feel comfortable asking those questions, and it's their care, right? They're paying for that appointment. So how do we better engage from both sides, I think, is definitely the answer.
Any more questions?
Come on. We still have 3 minutes.
The last question, kind of like on tangent with that question, do you all do any training for providers? Because all the work can't be on the patient side. Providers need to know what social determinants of health
Yes.
is. Okay, great.
Yes, we do. And I think in a lot of ways, I don't know about y'all, but sometimes I don't know what I don't know. Again, I was not from a public health background. If you would have been like, do you have any social determinants of health that are affecting you? I'd have been like, why are you speaking another language? I don't know what any of those words mean, right? So expecting, yes, we can teach patients this information, but expecting people to know things that they have no reason to know without some sort of intervention is, I think, unrealistic and unfair. And so, I think it's really up to us to do the work of making sure that our providers are equipped with the skills that they need in order to do this work well.
Hi. I actually work at a network in patient experience, and part of my work is coaching providers in real time, going through half a day, full day of appointments with their patients, and most of them find it extremely helpful. Just kind of building that trust with them first, that is important, but I'll also say more and more healthcare organizations are being forced to look at how they're training their staff on how to interact with patients around social determinants of health. And
They have to now.
Yeah, and one example, we have to start asking patients about things like sexual orientation and gender identity. Well, registration staff don't know how to have that conversation, but that's where we're being forced to ask it instead of, in the provider office with someone the patient trusts, unfortunately. But, my organization is, asking me and others to, provide this education. So it's just to say, I think the organizations are going to be forced to find ways to incorporate these ideas.
Yeah.
And those that do it well will reap the benefits of that because everyone will hear about it, right? If there's news that there's a doc in town who cares more than just what I said I was showing up for, that's going to help them too, right? So there's always an ROI story. It's just, can we get folks out of their daily routine and thinking about things a little bit differently? And how do we support it with data where necessary? Anyone else? Oh, one in the back.
Hi, thank you. So I had never heard of the Medi, and so I was just on there playing around in one of the zip codes nearby that's kind of underserved. Who do you see as the end users of that? Like, how are people supposed to find out about the Medi and how they can search for this stuff?
We are a nonprofit, so we're just doing the best we can to make sure that people know we exist. And so our hope is that community members who are not, I mean, everyone's a patient, but for us, we want like your cousin and your sister and your brother and the people at your church or your synagogue and the people down the street to know that the Medi exists. And then we also want secondarily to make sure that the community-based organizations that are on the platform who are providing the services know that the platform exists, so that when these people go to the platform, they are attempting to connect to services, that there is an organization that's ready to receive them. So we're doing the best that we can. Our hope is that this would be a tool that is in the hands of every person, especially people who are underserved.
Any final questions?
I just want to say that for those organizations that are here sitting in this room or attending this conference, if you go to our website, fill out the contact form. If you're not,
Hunter, will you give her the microphone?
if you're a nonprofit, you can reach out to us and we'll share with you how we can give you access to the tool. But more importantly, giving not only you access to the tool, but being able to provide data back to you about how those individuals who you're working with are using the platform and what they're seeking and how they're getting connected to services or not getting connected to services. So it's really for us as a nonprofit to work with nonprofits like yourselves or patient advocates like yourselves so that you have a tool that's in the toolbox. And as you are educated around the platform and its ease of use, make it available to your patients, your clients, your family members, the people you work, play, pray with, so that they have access to it as well. It is a national platform. It is, the platform's being used a lot in the large health systems today. And so for patients or individuals who may have some contact with the solution, with the technology, it's through their clinicians. And so, but it's available 24/7. If you've got internet access, you have access to it, whether it's through your mobile device or through a desktop. So we'd love for you to have access to it, and it's there for your use. And it's the work that we do, and hopefully be able to allow you to continue to do the work that you do.
I think I saw a question on this side, perhaps? No? Okay. Well, thank you all so much for your time. Thank you for engaging in this work, and please continue to do your good work for a good long time.